This is a discussion about ACL repair and whether a synthetic scaffold can help. It was presented at AANA Specialty Day on 2022. So to really consider this, we need to break apart the idea of an ACL repair and a synthetic scaffold and consider them independently. ACL repair was predominantly abandoned in the mid-1990s. There has been a renewed interest in the last decade with the idea that advancements in the arthroscopic techniques, as well as the emergence of biologics and orthopedics, can improve the outcomes that were encountered in the mid-1990s. There have been promising short to mid-term results by the developers, and when you think about technologies, first think about those who have been pioneering and developing some techniques, and then also think about the next level of early adopters, as many times the results aren't as consistent or more variable with the early adopters. Risk factors for failure have included young age, high pre-injury sports activity level, mid-substance ruptures, and impaired integrity of the ACL bundles and the synovial sheath. A clinical review from 2021 with Hudson's et al. Is a great resource for those interested in more. Now, thinking about a synthetic scaffold, this is something that has a history that really heated up in the mid-1980s. Initially as replacements to ACL grafts, but later as augments to grafts. Initial enthusiasm was later tempered by reports of complications, including device creep and failure, non-infectious knee effusions and synovitis, accumulation of synthetic material within the knee, and premature development of osteoarthritis. Gore-Tex and Dacron were two of these grafts that were withdrawn from the market in the early 1990s, and another graft was withdrawn in the 2000s. There's a systematic review from Batty et al. In Arthroscopy 2015, which is an excellent resource. When we think about these different synthetic grafts, they oftentimes involve polyethylene, polyesters, but also polypropylenes or polytetrafluorines. Ones for consideration when you think about all these grafts is a pretty high failure rate of around 33.6 seen with the Dacron grafts, and as low as with the large ligament at 2.6%. Now the effusions have also been variable, with the Gore-Tex having the highest effusion rates at 27.6 and the lowest at the leads, and then also the large with a pretty low effusion rate too. However, a recent single surgeon study looking at the long-term outcomes of the LARS found a 33% failure rate and then also 5% effusion rate, suggesting that that ligament itself was not immune to, pardon the pun, to this effusion and problems with the immune system. One device that's recently gotten more interest is the internal brace concept, which involves a braided polyethylene and polyestrine suture alongside of repairs or reconstructions. This idea is something that's been developed further and is the basis for some studies recently that we'll go into next. This internal brace has been studied with the ideas first developed in a preclinical animal model in animals. An initial canine study published in the Journal of Knee Surgery in 2019 with Patrick Smith and his colleagues. They implanted this braided polyethylene polyester suture alongside the ACL in canines, and in half of them they cut the ACL, as you see at the bottom two slides, to investigate a worst case scenario. They did arthroscopy at 4 and 6 months, and then at 6 months looked at histology after sacrificing the animals for visualization purposes. And what they found was that they found no to mild synovitis, and when they looked at a BTB reconstruction model, there was actually lower synovial grading scales than to their internal brace groups. This has been followed by many biomechanical studies, and hats off to Cohen Widgix and his team at Arthrex that have looked at different methods of repair regarding technique, and then also the addition of an internal brace and how it can biomechanically aid the construct. What they found initially was looking at repair constructs without the internal brace, and found that an adjustable type of repair was the strongest in terms of affording the highest forces with the lowest gap formation curves. They looked at the addition of an internal brace, and again found that an adjustable construct with an internal brace actually produced the lowest gap formation with the highest load bearing capacity. So their recommendation is with repairs to utilize the adjustable loop fixation devices that can help you in terms of having the lowest gap formation, and then also adding an internal brace, which again affords higher forces with lower gap formations. So after technique development by the developers and then refinement with biomechanical and animal studies, here's the clinical data that we have currently to review. And you have to break it down into the clinical study by the developers, which is always the first steps, followed by the clinical study of the early adopters, which is the next steps, and sometimes is a little bit less biased than the developers. This was published by Gordon McKay and his colleagues in 2015. They looked at 1-year follow-up in patients average age 34 with an N of 68, and they found a re-rupture rate of 1.5%. They then updated their data in 2019 of CESTA and found a re-rupture rate of 4.2%. The early adopters for review, we have from 2019 a cohort study that compared a reconstruction to repair in a very young cohort, an average age 14. And this group, the re-rupture rate was 48.8% in the repair group versus 4% in the reconstruction group. And that is a very young age cohort and a very high at-risk study. Next for review, we have from 2020 a cohort study in average age 33 that did not report re-rupture rates but found similar patient-reported outcomes. Then and also in 2020, we also had 3 case series for review, and it's interesting, if you look at the average age of the patients in these case studies, you'll see that the younger patients had a higher re-rupture rate, as in this study from DeHue in 2020, average age of 27 had a 15% re-rupture rate. And then the following case series, average age of 33, had an 11% re-rupture rate. And then this case series in average age of 42 had a 3% re-rupture rate. And so, in conclusion, the history of synthetics and ACL repair sits a little bit hard on the gut. The braided internal brace model is encouraging and has safety profile that's promising in a canine model. The biomechanical development of optimizing construct is of interest. ACL repair requires deliberate patient selection. You have to temper the excitement of the early developers with the clarity that is developed further with the early adopters. And we're excited to wait the next round of clinical results with optimized constructs. And we always have to think about this pyramid of evidence, starting at the bench and then develop bedside for evidence-based medicine. I appreciate your attention for this presentation.